Okay, so what I want to talk about today are joints, the type that we find in the skeleton. And so what joints are a place of union between two or more bones of the skeleton. They're where two bones meet, basically. And we also call these an articulation. So why are joints important? Well, movement of the skeleton is restricted to the joints. Wherever there's movement of the skeleton, the reason that's able to occur is because there's a joint in that area. In other locations, though, joints restrict movement. They hold things together. So they do have multiple functions. So we can classify joints based on how the bones are joined together or separated, however you want to look at it here. And we have three possibilities. They can be joined together by fibrous tissue, by cartilage, or by fluid. And so the first type, these fibrous joints, are joined together by fibers, in particular by these tough collagen fibers here. And the sutures are an example of that, of fibrous joints. Okay, then we have cartilaginous joints. And cartilaginous joints are joined by cartilage, and the pubic symphysis is a good idea of this. And I want to point out that these fibrous joints and these cartilaginous joints are highly immovable. Well, most fibrous joints are immovable, and then cartilage joints or cartilaginous joints are not highly movable. So we're not getting a lot of movement there. But then we come to synovial joints. And synovial joints are joints where the bones are separated by synovial fluid. So this is all synovial fluid in here separating the bones. And these joints are highly movable. They're specialized for movement. Okay, so let's take a look at some fibrous joints. We'll spend most of the time on synovial joints, but let's take a look at some fibrous joints here. And there's three different types. There's sutures, there's something called a gomphosis, and there's something called a syndesmosis. These are all different types of fibrous joints. And we'll start with the sutures. And we've talked about this before in the skull, but suture means sewing together. So it's a sewing together of bones. You have these wavy bony edges right there that are interlocked and bound by short connective tissue fibers, by those collagen fibers there. And these are only found between the bones of the skull, these sutures. And like we talked about, up until middle age, these fibrous joints, these sutures allow for a little bit of movement, a little bit of expansion. But about middle age, they do become ossified, in which case they're no longer able to expand. But we do need this fibrous connection during infancy, during childhood, during puberty, during all that kind of stuff, because it allows the skull to expand as the brain grows. These are some different types of sutures. These serrated sutures, what are called lap sutures, plain sutures. This is just for your personal reference here. And then we have another type of fibrous joint called a gomphosis. And gomphosis means bolting together. So what this is how we bind our teeth in the surrounding tooth socket. So here we have a tooth. Here's the tooth socket, and the tooth is bound to that tooth socket by fibrous tissue. Okay, so those are short collagen fibers in there that are binding the tooth to the tooth socket. And this particular fibrous joint is the periodontal ligament. Peri means around, odontus means tooth. And this is not meant to move, as you guys know. Okay, it's really tough, it's really strong, and it's not meant to move. So if you need to take a tooth out, let's say your wisdom teeth, you need to get in there and get those with laser or with cutting or something, because they don't come out normally. Tooth disease, tooth decay. When periodontal diseases, what happens here is that those periodontal ligaments become compromised. Okay, and they lose their integrity, and that allows the tooth to fall out. There's another type of fibrous joint called a syndesmosis, and I'm not concerned that you know this name, syndesmosis. I'm really not concerned that you know necessarily gomphosis, but I want you to know about these types of joints. So what a syndesmosis is well, it's also a fibrous joint, and we find this in specific locations here. Okay, here we go. These are joints held together by a ligament. And so the tibia and the fibula down here at the distal end are held together by a ligament. The ulna and radius are held together by this ligament here. And again, these are not supposed to move. Okay, any movement here we describe as give, and we don't want a lot of give here. What type of tissue is this made out of? You guys know that these are collagen fibers in there. And so these are going to be dense, regular connective tissue. Collagen fibers running in the same direction here. Okay, and then we have cartilaginous joints, as the name implies, bones connected by cartilage. And again, these are not highly movable. So we'll take a look at some of the places we find these in the body. A good example of these are the intervertebral discs, which separate the vertebral bodies. This pad of cartilage that joins the two pubic bones there, the pubic symphysis, is a cartilaginous joint. Specifically, the cartilage that this is made out of is fibrocartilage. So what does this fibrocartilage do? Well, it acts as a shock absorber. Okay, especially for these vertebral discs, this fibrocartilage absorbs some of the shock, some of the weight that's traveling through the vertebral column. It does permit a limited amount of movement here, but pretty much it's designed for strength and flexibility. Then we have another type of cartilaginous joint, and these are bones that are united by hyaline cartilage, so a different type of cartilage, and we'll talk about these different types. Here we have the sternum. This is specifically the manubrium, and this is rib number 1. So something that's not in here is the clavicle. The clavicles would be right there. So the joint that connects the sternum to the first rib is cartilage. So this is cartilage right there, and that's hyaline cartilage, and that's immovable. Another place we find a hyaline cartilage joint is in what we call our growth plate. And we'll talk about this process here, but this is your growth plate. That's hyaline cartilage. And during puberty, that's what allows, during infancy, childhood, and puberty, this is what allows the long bones to grow. There's a nice band of hyaline cartilage there. Okay, but what we're going to spend most of our time on are synovial joints. And synovial joints are specialized for movement. They permit a wide range of movement. So what parts of the body do we have a wide range of movement? Well, how about the appendicular skeleton? So we're going to find synovial joints pretty much at the ends of all the long bones, the bones of the upper and lower limbs, shoulder, elbow, wrist, hand, fingers, hip, knee, ankle, foot, toes, all that kind of stuff. Okay, so I want to go through some characteristics of synovial joints. They all have some same basic characteristics. And one of those is they all have a joint capsule. So all synovial joints are enclosed by a joint capsule, which strengthens it so the bones aren't pulled apart, essentially. So here we have our generic synovial joint with a couple bones here. And on the outside, we have a joint capsule. Holds the bones together so they can't be pulled apart. Here we have the lower limbs, and this is from essential anatomy. This is with all the muscles and ligaments and all that kind of stuff. Then you take all that stuff away, and what you're left with down here is the joint capsule. So this is the joint capsule that for the knee. And not surprisingly, This is made up of dense, irregular connective tissue, tough collagen fibers, which allow it to resist stretch in multiple directions. We don't want it to be stretched, and we know that the knee joint gets pulled in multiple directions, so it resists that stretch. It holds it together, holds the bones together. And this is kind of cool. These are all just different synovial joints of the body, and it shows their joint capsules. We see these joints in books and stuff like that a lot of times without the joint capsule on it, but they all have one. So here's the shoulder joint, and there you can see the capsule around it. Here's the elbow joint with the capsule, and then here's the hand. All the carpals, the wrist bones are synovial joints, so those have capsules around them. All the metacarpals there. All the phalanges, all these individual joints are synovial joints, and they all have joint capsules around them. So another thing that all synovial joints have is they're supplied by sensory nerves and blood vessels that are going to supply the interior and the exterior of the joint. This is a living, moving thing here. We also have this joint cavity is filled with synovial fluid. And you guys know that because that's how they get their name. But within this joint capsule, this is all synovial fluid separating the bones. And you have a synovial membrane that lines the joint capsule right there. And the synovial membrane is responsible for producing the synovial fluid that fills the joint cavity. And in a little later on, we'll talk about some of the functions of this synovial fluid here, but I'll bet you can already guess some of them. All synovial joints also have articular cartilages, what we call articular cartilages. And this is cartilage that's found at the ends of long bones. So here's an articular cartilage there. There's another one there. And as we'll learn about cartilage, cartilage is mostly water. And so these articular cartilages are able to absorb compression to make sure that these bones, when there's pressure here, that they don't make direct contact. So they're protecting the bones. And this is hyaline cartilage. Another thing that we find in joints, synovial joints, are what we call bursa. So this is the knee joint here. It's a sagittal view. And what these bursa are is they're fluid-filled pockets that are filled with synovial fluid. There's one there, there. They're fluid-filled pockets filled with synovial fluid. And we find these basically where a tendon or ligament would otherwise rub against a tissue. So let's look at this guy up here. This is a quadricep muscle, and this is the tendon for that quadricep muscle attaching to the patella. And so here we have, there's the tendon, and then we have the femur in back of it. And we don't want the femur to rub against the tendon, so we separate that by a bursa. It's this tubular structure that's filled with synovial fluid. Here's another one here. This is the prepatellar bursa. And then there's another one right there. But again, you can see that it's protecting this tendon, or actually this is a ligament, the patellar ligament, from rubbing against the tibia. Yeah, and this is a good picture of what it does here. So there's your bursa, and basically this is where the tendon would rub against the bone, but instead this bursa rolls and it prevents friction between these two. There's also another similar item called a tendon sheath, and basically this is a tubular bursa, and this wraps around tendons. So this is this is the shoulder joint. The bicep muscle is down there, and this is the tendon for the bicep. And the tendon for the bicep runs all the way up around the shoulder, and it connects over here. And to prevent friction with the humerus, we wrap it with a tendon sheath, which is just a tubular bursa. Now you can irritate these bursa if you put a lot of pressure on them, a lot of compression on them. They can get inflammation and swell and cause pain and stuff like this. This is pre-burtellar bursitis. This is, you have a bursa on your elbow that if you have a lot of pressure on it, then you can cause that to become inflamed as well. Okay, and now I want to take a look at the knee joint to kind of describe some of these last characteristics of synovial joints. So you guys are familiar with this. Here's the femur, here's the tibia, and that's what forms our knee joint, but we also have the patella out here as well. So basically what we're looking at in this picture is they're pulling back the femur. So we can see the articular surfaces of the femur and the tibia. And so what we're looking at here, these are the articular surfaces. These are the femoral condyles, and these are the tibial condyles right there. Those are the articulating surfaces that form the knee joint. And what I want to point out here is that these articulating surfaces are lined with articular cartilage. You think you're seeing the bone there, which you are kind of through it, but this is all lined with articular cartilage, with hyaline cartilage that prevents bone-to-bone contact at the knee and other synovial joints. So synovial joints can also have what we call extracapsular ligaments. These are ligaments that are outside the joint capsule, and these connect bone to bone. We find these in the knee joint among other places, and there's two main ones. There's a lateral collateral ligament and there's a medial collateral ligament here. So this would be the right leg. This is lateral collateral ligament, medial collateral ligament. There it is over there. And as you guys can imagine, these serve to support the joint. They reinforce the synovial joints and hold them together. In this case, these ligaments are going to prevent lateral movement of the knee joint. Don't want that. We also have ligaments that we can find within the joint capsule, and a couple specialized ones that we find within the knee are the anterior cruciate ligament and the posterior cruciate ligament. So the ACL is attached to the anterior tibia, so the front side of the tibia, and then it goes back and attaches to the posterior side of the femur. And what that does is it prevents forward sliding of the tibia on the femur, so it prevents the tibia from moving forward from the femur. Again, we don't want that, and the ACL prevents that. And then the PCL, the posterior cruciate ligament, prevents forward sliding of the femur on the tibia. So, this is preventing unnecessary or unwanted forward sliding of these bones. It's a nice diagram, sagittal view there. And unfortunately, we can tear these, especially when the leg is planted and the knee rotates. It can tear these, the ACL, the PCL, and it's a long recovery. Now you can test for this. Let's say you do have a suspected ACL tear. How are you going to test for this? Well, they can do what's called the anterior drawer test, where they have the knee at an angle here, knees at a 90-degree angle, and I'd hope they do this under a little sedation or whatnot. But what they do is grab the tibia and see if it slides forward. It's not supposed to do that, but if your ACL is damaged, then you will get forward sliding. And if you get a certain amount of movement forward sliding, then that indicates that there is damage to the ACL. And they call this the anterior drawer test because it's like you're opening a drawer and you're moving it anteriorly. Another thing we can find in synovial joints, and that we do find in the knee joint specifically, are menisci. And menisci are made up of fibrocartilage that do different things here. But specifically in the knee, we have two of them, and these are found on the tibia. And we have a medial meniscus that's located medially, and a lateral meniscus here. And what are they doing? Okay, you can see that they kind of have this ridge there. So one of the things they do is they deepen the articular surface. Okay, they deepen the joint, deepen the surface, so the femur sits in there more snugly, which also prevents side-to-side rocking of the femur on the tibia. And it also absorbs some shock. And then we also have fat in there. Fat can be found at the periphery of the joint, and it's there for protection, fills the spaces up, packaging material, packs all that stuff together, cushions it, does all that kind of good stuff. Okay, now back to the synovial fluid here. So these joint capsules are filled with synovial fluid. What does it do? Well, not surprisingly, it provides lubrication. It reduces friction between those cartilaginous surfaces. So it's actually less friction than two pieces of ice rubbing together. So it lubricates it, it prevents friction. And you do need to warm this up, just like motor oil, for synovial fluid to do its job, you need to warm it up so it gets it has a certain stickiness to it, but you also want it to thin out. So you want it to stick to the surfaces of the articular cartilages, but not be too sticky, and it requires warming up to get to that point. Now this is pretty cool. Another thing that the synovial fluid does is it nourishes the chondrocytes. So here we have articular cartilage here with our chondrocytes in it that are maintaining the health of the cartilage there. And what do you guys remember about cartilage? It's avascular. So it doesn't have a direct blood supply to it. So these chondrocytes, they need to get glucose, they need to get oxygen, so they need to get all that stuff, and they need to get rid of waste, CO2, metabolic waste, all that kind of stuff. Well, how do they do that? Well, it has to do with this synovial fluid circulation that occurs during joint movement. So what happens is when the joint compresses, what happens is synovial fluid is forced out of the articular cartilage. And with it goes cellular waste. And so synovial fluid is forced out and cellular waste goes along with it. And then when the joint expands and there's no longer compression, then synovial fluid is pulled back in to the articular cartilage, and with it goes oxygen and glucose and all the other important stuff that it needs. Synovial fluid acts as a shock absorber. Okay. So the way I want to finish up here are talking about the actions of synovial joints, the different types of actions of synovial joints. I said that these are designed for a wide range of movement, and you guys will find that out. So we'll talk about these specific types of movements that we find at synovial joints. And we're going to start at the wrist here. These are movements at the wrist. So we're going to start in the extended position. Here's the extended position. It's at 180 degrees. So if we take this extended position and we decrease the angle of that joint, okay, we move the hand this way, that movement occurs at the wrist joint. But if we move the hand this way and decrease the angle of the joint, then that's called flexion. So we're decreasing the angle of the joint. It brings the articulating bones closer together. That's flexion. Now, if we're in the flex position and we increase the angle of that joint, bring it back up like so, that's called extension. And then if we take it beyond the anatomical position here, beyond what we might call the normal range of the joint, then that's called hyperextension. How about at the shoulder joint? So here's the shoulder joint here, and you guys, the shoulder joint is a ball and socket joint. The head of the humerus is the ball, and the socket is the glenoid cavity. And ball and socket joints allow for a wide range of movement, including flexion and extension. So here we have, let's see, this is the Again, these are occurring at the shoulder joint here. And this is in the extended position. And if you decrease the angle of the joint, so extended position, and bring that forward, decrease the angle of the joint, that's called flexion. Bring it back to this position, and that's called extension. Take it back further, and that's called hyperextension. Okay, then we have the elbow joint, and the elbow joint is what we call a hinge joint. It has a cylinder that fits in this trough down there. And so at the elbow joint, the cylinder is the trochlea, and it fits in this trough, which is the trochlear notch. It fits in like so. Now, this, I should go back. The ball and socket joint allows for multi-axial movement. It allows for all of these different types of movements there, as we'll see. But the hinge joint allows for movement in one direction. And specifically, it allows for flexion and extension. So here we have the elbow in the extended position. Bring it up like so. That's flexion. Bring it back down. We have extension. And this is one of the joints where you definitely do not want to have hyperextension. Okay, hyperextension is going to tear ligaments in there and cause some damage. So flexion, extension, no hyperextension. Okay, now moving south here, we have the hip joint, also called the coxal joint. And the hip joint is also a ball and socket joint. And specifically, we have the head of the femur, the ball that fits in the socket, which is the acetabulum. So this also has a wide range of movement, but including flexion and extension. So here we'll say, we'll start in the hyperextended position here. And if you move that forward, that's flexion. So this is all flexion here. And they're showing that right here, but I wish they would have kept the leg straight, because the movement is occurring at the hip joint here. We're taking the whole leg and we're moving the leg forward. Okay, this motion that they're showing right there is at the knee. So if you have this leg here and you bring it all the way forward like so, then that's called flexion at the hip. Bring it back down, that's extension at the hip, and we can take that one step further. This is a joint that we can hyperextend the hip joint at. Okay, then down below that we have the knee joint, and the knee joint is a hinge joint just like the elbow, and it's formed from the femoral condyles forming an articular surface with the tibial condyles down there. So just like the elbow, it's restricted to one movement, which is, so if this is the extended position, actually that's backwards there. No, okay, yeah, right. So this is in the extended position, and this motion there is flexion. So we're decreasing the angle of the joint there. Then we bring it back out. That's extension. And this is another joint where we do not want hyperextension of the knee. These are some more flexion and extension things going on here. So this is the back or the vertebral column. Flexion of the back. Extension of the back. Hyperextension of the back. Here we have the neck. Flexion of the neck. Extension of the neck. Hyperextension of the neck. And here it's just a different picture kind of showing the same thing. Here's the neck. Here's our elbow. Flexion. Extension. Here's our hip. Flexion. Extension. Hyperextension, or I guess they're still calling this extension here. something I want to point out here is all of these flexion and extension motions have something in common. Okay, look at all these motions here. And what these all have in common is they're all moving in the sagittal plane. And if I was in front of you here, I'd be moving all these joints in the sagittal plane so you could see this. But yeah, all these move in the sagittal plane. Here we go again at the fingers, all of these different, this is flexion, 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 okay, flexion, extension, hyperextension. Then there's some special flexion motions, and these are plantar flexion and dorsiflexion. These occur at the ankle joint. And plantar flexion is when the toes get pointed down. So you depress the toes, and that's plantar flexion. And as we'll learn in the skeletal muscle, you're not actually pointing your toes down, you're lifting your heel up because your calf muscles back here contract, pull on the calcaneus, and that lifts your heel up. And by doing so, it points your toes down, and that's called plantar flexion. You bring those back up, and that's called dorsiflexion. Okay, now we have another set of motions called abduction and adduction. And it's best to separate these, to call these abduction and adduction instead of just abduction and adduction, because these sound very similar. And so when we say these, we say abduction, adduction. And what these movements do is they refer to movements away from the midline. So here's the midline of the body, and movements away from the midline are abduction. Movements toward the midline are adduction. So we can start with the hands here. This is anatomical position. If you take your fingers and they're together and you spread them out, that is abduction. You bring them back together, that's adduction. How about at the shoulder? Abduction. Bring it back in, adduction. How about at the hip? Abduction. Bring it back in, adduction. And something all these movements have in common is they're all moving in the frontal or the coronal plane. Another type of movement that we have is rotation. And rotation is where we turn a bone on its axis here. So we have lateral rotation and medial rotation. And as you guys can pick up, lateral rotation is when you move laterally away from the midline. Medial rotation is when you move it back toward the midline. So here's rotation at the neck, and you guys should, by the exam time before that, you should know the vertebra, or the bones, the vertebra that are responsible for this motion. But here's rotation right there. Is that lateral or medial? That's lateral rotation. Then you bring it back in, and that's medial rotation. Same thing goes at the hip here. So this is occurring at the ball and socket joint at the hip. Here you can see your foot is facing forward. So you can do lateral rotation, and you can see that the foot moves out, and then bring it back in. That's medial rotation, and the foot moves back in, and the whole leg moves with it. Here's all these different possible hip movements here, and again, these are all ball and socket movements right here, including rotation, which they're calling external and internal in this case instead of medial and lateral. Medial and lateral is good for us though. Shoulder movements. Again, all these ball and sockets. And if If you move that out, that's lateral rotation. Move that back in, that's medial rotation. This is occurring at the shoulder. Okay, then we have some other specialized movements that we find in synovial joints. And one of those is called opposition. And what opposition does, it allows us to touch the pad of our thumb to the tips of the fingers. And you're like, oh, okay, what's the big deal with that? Well, hurt your thumb and see how you do with normal day-to-day tasks. So this opposition allows us to grasp things, have fine contact with things, and really manipulate our environment the way we want to. And we're one of the only animals that has this ability, that has opposition. Another type of specialized movement is inversion and eversion. Inversion is when the sole of the foot moves medially. And if you've ever had an inversion sprain, that's not fun. You tear a bunch of those ligaments right there. And then eversion is when it moves back out, which is difficult to do. Well, it's not difficult if you go from inversion back to the normal position, but extending it out further is difficult. Supination and pronation. So here we are in the anatomical position, and in the anatomical position, what bone is that right there? Follows along the thumb, that's the radius, and so this is the ulna. I'll make it better here. Here's the radius, and here's the ulna. And if you rotate your forearm, and so your palm goes along with it, so the palm is facing forward here, and if you rotate it so the palm faces posteriorly, then that motion is called pronation. And what happens in that case is the radius forms an X over the ulna. And then if you move it back, if you go from the palm facing backwards to the palm facing forward, that's called supination. And then those bones are parallel again. Protraction and retraction. Protraction, forward. Retraction, backwards. So this is of the mandible. Again, of the mandible, move the mandible down, that's depression. Move it up, that's elevation. And then here's the scapula back here. And the scapula, like we talked about the other day, if this is the vertebra, the scapula on the posterior side is only connected to the vertebra by skeletal muscles. So there's a wide range of motion back there, and these skeletal muscles can contract and move the scapula along with it. So you can elevate the scapula, depress it. You can adduction. Then you can move them back out, and that's abduction. And different rotations as well. And if we have time, we'll go over this in class, just because it's a good exercise. But here's somebody hiking. Just found this on the internet, and there's a lot of different motions going on, a lot of different joint motions. The ones that are circled here, but certainly there's a lot more besides that. So we can go through theirs. Same goes with this scenario here. A lot of joint motions going on. Synovial joint motions. And then what these last few slides are this, and this. As the name says, this is an appendix of the joints of the body. So basically these are all the different types of joints that you find in the body, and it's a good reference. Obviously you don't have to memorize these, but it's a good reference. So for instance, here we are at this joint there, which is found in the skull. These are the articulating bones. It's a fibrous joint, a suture joint, and then it tells you what type of movement it has. Okay, so there's that. Here's your sternoclavicular joint, acromioclavicular joint. Here's your shoulder joint. Bones are the scapula and humerus. This is a synovial ball and socket joint, and there's all sorts of movements associated with that. And then look at these. All of these are synovial joints. Then down here in the lower limbs, again, you get down here, and almost all of these are synovial joints. This one here that's not is that fibrous joint that we were talking about that links the tibia to the fibula. Okay.